Hello, everyone, and welcome back to the Neurotransmitters podcast, a podcast about everything related to clinical neurology. I am very fortunate today to have a special guest with me, Dr. Samantha Fernandez from the Baylor College of Medicine in Houston, Texas. Dr. Fernandez, thank you so much for joining me today.
No, thank you so much for having me. I'm pretty excited that I get to have this conversation with you.
Well, me too. So just to kind of start things off a little bit, you are a fellow neurologist, and just tell me a little bit about what path led you into neurology to start with.
Yeah, so I knew I wanted to go into neuro pretty early on. I think it was MS2, and it was the easiest subject for me. I did, it wasn't taking too long to learn things. I really enjoyed it. The localization part of it, I really loved. It's I feel like the one specialty that you don't need a bunch of imaging or labs to kind of diagnose stuff. It's helpful to have it, but
Oh, sure.
if you know your anatomy, your neurophys, you kind of have an idea of what's going on. So that's what drew me to neuro. But so I went to med school in Mexico.
Oh,
And
okay.
yeah, and we don't have as many subspecialties, I guess, as we have here. So going into neurocritical care was not even in my mind, but I did know that I really, really liked neuro. So that was my plan for the longest time. And I mean, clearly then it changed a little bit,
Yeah.
but yeah, I just knew I wanted to do neuro pretty early on.
That's awesome. And so you started, obviously you went through the whole medical school pathway. You matched into Baylor, an excellent program.
Yeah, love it.
So you've been practicing in Houston now or in training there for a few years, and you had gone in for surgery, if I remember correctly. Is that right?
Yes, that is correct.
Tell me a little bit about that.
So it's actually a little bit funny, but I before residency, actually before even I was in research, which was 4 years before residency, I started having some weird pain. It wasn't related to anything that I ate, but it was kind of in my back, actually, right side in my back. Sort of the flank, but a little bit higher up. And it was really, really odd. I didn't know what it was. Then it would be epigastric. So I was super confused. But of course, I thought that I knew what was going on. I started taking Nexium. And for some reason, it kind of improved. So for the longest time, I thought I have gastritis, I have GERD, and, Nexium is helping me. But then it stopped helping me. And I was actually 6 months into intern year. 6 months into intern year, and I was having biliary colic. Oh, well, before that, I was, I finally went to GI, to a GI specialist, did an ultrasound, and she said that I had a pretty big gallstone, essentially the size of my gallbladder.
Ooh.
Yeah, I know. But in my mind was well, it's big, it can't come out. So,
right. Yes, true.
So I thought I'm not going to be too concerned about this. I'll just change my diet and it's going to get better. And it did. But eventually it started giving me more trouble. It got to a point where I was having an episode of biliary colic every month, at least once a month.
That's right.
And I said, well, yeah, I might consider surgery down the line, but it wasn't anything crazy. And then November, I want to say 2020. I don't know what happened, but it just got out of control. I was having constant biliary colic, every minute of every day. I couldn't eat. I could barely drink water. I lost 15, 17 pounds in a month, which I was happy about, but wasn't healthy.
Right.
So I went to see one of the surgeons at Baylor, and he's like, yeah, we can do it in 3 weeks. And so we scheduled everything. I was actually going to go on an anniversary trip with my husband because it was going to be our first year anniversary. And yeah, and so going for the surgery, super simple. And I was pretty scared. I've never had any kind of surgery. And so I was pretty nervous beforehand. But, I was looking at statistics, even like mortality rate, and I think it was like a 1.6, 1.9 mortality rate. So I'm like, okay, stop worrying. So I go in, and all I remember was going to the OR and then starting to wake up. And I hear like just commotion in the room. Like everybody was kind of freaked out. And in my mind, I'm just thinking, oh, like it's over. They're just, about to change me like to another bed, take me to PACU. But then I hear I don't have a pulse. Literally, someone saying like I don't have a pulse, and it freaks me out.
Yeah.
And then I feel pain. Like it wasn't pain actually; it was more pressure, like on my chest. And I was thinking to myself, like, you have a tube down your throat. Like, why would you have pain and feel like you can't breathe? And I remember even trying to take a deep breath, and I felt the tube. So I wasn't sure why it felt like I couldn't. It felt like I had an elephant sitting on my chest, and I could not breathe, and it was just a lot of pressure. So there's still commotion around me, and all of a sudden, I don't feel the elephant in my chest anymore, but I feel horrible pain on like the sides of my chest.
Oh, no.
So I had a pneumothorax, and they had to place in chest tubes. But of course, they think I was in PEA. So they didn't, like put lidocaine. No, it was just cut, put the chest tubes in, and I can tell you it was the most excruciating pain like I have ever felt in my
I
life.
can only imagine.
Yeah, it was pretty painful. But that's kind of when I realized that there's something really wrong, going on. And I started, I'm thinking, okay, what are they going to look for right now? They're going to try to see if I'm opening my eyes, if I'm wiggling my toes, or if I'm moving my fingers, because that's what we ask our patients, right? When they're unconscious. So I tried to do that. I remember I think they had me like this on the table, and my head was turning to the left, and my eyes were closed, but not completely closed. So I could kind of see my hand, and I'm trying to move my fingers, and I don't see it moving. I try to move the other hand. I don't feel anything moving. Then I try to wiggle my toes. I also can't, and definitely couldn't open my eyes. Like I really tried. And so they're changing me. Well, not changing me, but I think they were like getting some X-ray. So they were moving me around. Then I hear someone say, like, Miss Fernandez, I'm so sorry, as they were about to place my IJ. Yeah, it was not fun. And, like while all of this is going on, I hear the anesthesiologist say, we're going to have to get the ECMO team. And that's when it really hit me. And so, I guess if anybody else had heard ECMO team, they don't
know what that
they
means,
don't.
yeah.
Yeah. But that's when I was like, okay, this is pretty bad.
For people who are listening who may not be familiar with ECMO, could you just give a kind of 10,000 foot view?
Yeah. So essentially, they like it's a huge system where they like pump blood for you and like oxygenate it because your body is not able to get the amount of oxygen that it needs to in the blood. So essentially, you have like a circulatory system that's not in your body. It's a machine.
Right. Yeah.
So that usually means that someone is really, really sick.
Right.
Right. It's a pretty specialized procedure. I think most physicians that don't do ECMO are very scared of it. I know I'm pretty scared of ECMO.
There's a lot of things you have to know to do it right, right?
Yeah, I know. And the lines are huge. So anyway, so I hear that they might need to call the ECMO team, and they actually call them. And so I feel like I am about to fall asleep. And, what kept on going through my mind was don't fall asleep because it doesn't mean that you're falling asleep. It means you're going to die. So I just kept trying and trying and trying to wake up, and I wasn't able to. And then finally, they were actually cleaning the area in order to put the line for ECMO.
Hmm.
And somehow I just woke up. They said that I opened my eyes first, which also kind of was weird. They said usually you'll start moving and then you open your eyes, but I went straight to opening my eyes. My oxygen, my oxygen saturation went up. It was in the 40s, I think, 30s, 40s, and all of a sudden goes up to 80s, 90s. Um, I mean, I have a pulse bag, of course, by then, and and that's all I remember. Then I don't know what happened, but I know that they had the interventional cardiology team come by. There were like a bunch of people in there. And honestly, my thought was, these are all my coworkers. I'm naked on this table, and there's a bunch of people looking at me. So it wasn't the best. But
Yeah, it's literally that nightmare everyone has in grade school.
yes, and it was happening to me.
Oh my gosh.
So then I remember feeling like a really big tube down my throat. And I was confused because I already had the ET tube.
Hmm.
So the breathing tube. It turns out they did an echo, like a TEE.
Oh.
So it was a probe. Very uncomfortable. Um, very, very uncomfortable. But they did the little procedure there. After that, they take me to the recovery room. And this is pretty tricky because it was around COVID. Well, it was during COVID. The
Hmm.
vaccine hadn't even come out yet.
Right.
So, family members are not allowed to visit. My mom was here. My husband was with her, but they could not come see me.
Oh, geez.
So that was, yeah, I mean, eventually they did, but my surgeon was amazing. He immediately called my husband, told him what was going on, and said, she didn't have enough oxygen go into her brain for quite amount of time, so we don't know what she's gonna be like when she wakes up. Um, my husband tells my best friend who's an OB-GYN
Hmm.
about this, and then she calls the surgeon. He gives her more updates. My mom is having the most horrible night of her life, and I'm I'm pretty unaware by this point. When I was in the recovery area, I sort of remember. So I wake up, and the first thing I see is the surgery resident who's crying, and she was bawling, and she tells me, "You're really scared us in there." And I feel like that really created a pretty special bond between us. I mean, I see her now at work, and it's like,
Yeah.
you saved my life, you know?
Right.
And so, yeah, um, she, yeah, she's bawling, and she says, like, what can I do for you? Like, tell me anything you need. And I keep on, like, pointing to the tube because it's super uncomfortable.
Oh, yeah.
They had, they had me sort of sedated, but even like, okay, so I remember it was so uncomfortable that I kind of had to teach myself to breathe with it as opposed to
Hmm.
just like over kind of breathing over the butt, because that
Hmm.
was super uncomfortable. So somehow I got them to extubate me at like 3 a.m. or something. It was great.
Which we all know how people don't like overnight extubations.
Yeah, they don't. So it had to be very convincing.
Yes.
The anesthesiologist, I remember, came, examined me, and I was following commands. I was answering questions. I was writing.
Hmm.
They gave me a notepad. I was writing. It's pretty funny because I remember they were checking my cranial nerves, and they asked me to raise my eyebrows, and I just shake my head, and they freak out. They're like, "Please, like, can you try? Can you
Yeah.
try?"
Yes.
And I asked them to give me the notepad, and I just write Botox. So they were super relieved. But I wanted to mess with them a little bit more, but I could not.
Oh my
Um,
goodness.
I know. But finally, they took the tube out. I was texting. That night I was on the phone with my mom, with my husband, and I was just like, okay, something crazy happened, but I'm here. And my gallbladder was not taken out.
Oh my God.
I know, I know. But has not given me trouble in almost like 2.5 years. So I don't know what they did, but it worked.
It doesn't sound like an option that most people would pursue.
Oh, definitely not.
So I have so many questions. So first of all, did they ever figure out why you went into cardiac arrest in the first place?
Yeah, so there's a few theories that they have. One of
Hmm.
them is that they had already done the pneumoperitoneum. So essentially they put gas in my stomach, right, to inflate it because it was laparoscopic. So they needed the
Hmm.
space to go in with all their little toys and do the surgery.
Right.
So I have a pretty short torso. So what they
Okay.
think is that it kept on pushing like my diaphragm and my lungs upward,
Oh,
and my right mainstem bronchus was intubated. And they kept on retracting. They pulled
yeah.
it back, they pulled the tube back because there are x-rays, like I saw all of them.
Hmm.
But every time after they retracted, it would go to that one again.
That's very strange.
That was really odd, yeah.
Yeah.
And I mean, I had a pretty experienced anesthesiologist, pretty experienced surgeons. Like I trust that, and I trust them all with my life, you know? So that's after a bunch of tests that they did, that's what they think happened because it was respiratory arrest first for like
Hmm.
15 minutes or so, and then
Gotcha.
the cardiac arrest, essentially.
Okay. And I guess the second piece would be, most people don't wake up in the operating room. So I know there are some people who are like, fast metabolizers of anesthesia, or, I mean, was it similar, or was it just that they had turned it off when all this other stuff started going down?
So it was still on. That's why they couldn't explain why I was so aware. Um,
Yeah.
I'm pretty sure that when I first told them, "Oh, I could hear you," they were like, "Yes, yes, you did." But
Right.
then I started telling them things that did happen. They're like,
Mm-hmm.
"Oh my gosh, so the oxygen in my blood, my PO2 was in the 20s, like the entire time."
Mm-hmm.
So they couldn't explain why. But I went to PubMed and I did a little bit of literature search, and it seems like it's about like one point, I think, don't quote me on this, but I think it's like 1.2, 1.6 of cardiac arrest where they are aware.
Not the majority.
No, definitely not. And there's crazy cases where people are like awake talking to you
Mm-hmm.
as you're getting, like chest compressions,
Right.
even though they're still in like cardiac arrest.
Interesting. And I'm sure you're familiar, like with BIS monitors and things like that, the bispectral indexes, which I know are not necessarily used in all routine surgeries. But I assume that they probably weren't monitoring functional brain activity in your case. Otherwise, they would have known that like, you weren't really in deep anesthesia.
Right, exactly. I don't remember honestly having any sort of, like this monitor or anything like that.
Hmm.
Um, Another thing that I did wonder, I never asked to be honest, but I did look at all my vital signs.
Yeah.
I don't know if like my heart rate at some point like went up and, like with the pain, because it was a lot of pain. Like if I have ever had like an adrenaline rush, it was that moment. Um, I don't know if it did anything. I don't think it did. So nothing really objective for them to know that I was aware.
That is crazy. So, you've been through all this. Now we move on to the recovery phase. What did that look like?
So I had Takotsubo. So my heart pretty much took a hit from the arrest, and I had an ejection fraction of like 20, 25,
Oh my.
I think, that eventually went up to like 30 when I left the hospital. I was in the
Hmm.
hospital for 5 days, 3 days in the ICU, and then 2 days on the regular floor. Um, I started getting better. I did not seem to need any rehab. The physical therapist evaluated me, and they're like, "No, you're fine. You can do everything." So I just needed to take it easy, take my medications, and just slowly kind of, not workout, but just walk a little bit more and slowly try to go back to my normal life. So I called my program director. So I was an intern year. So I was like part medicine and part neurology.
Right, right.
But they were super understanding. They were like, how long do you need? 2 months? I'm like, no,
Yeah.
I don't think so.
Yeah.
But um, they were willing to just give me as much time as I needed.
Hmm.
They were super sweet, super understanding. My co-residents actually went all, well, not all of them, but a lot of them just went to see me when I was still in the hospital, which
Yeah.
was, of course, pretty cool. And
Yeah.
then I go back home and I was out for 3 weeks, I think.
Hmm.
Besides the hospital, I was out of I worked for 3 weeks. Then I went back and it physically, honestly, it wasn't too bad. Just had to take it easy. Working 3, 4 hours would put me out for 8. Like I was so fatigued.
Yeah, and I think, for those who haven't gone through medical training, the life of an intern is one of constant sleep deprivation and long hours,
Yeah.
capped, quote unquote, at 80 hours a week, right? Which we all know.
Right.
There's a little bit of blurriness around the edges of those numbers. But
Exactly.
yeah, for someone who'd just been through something like that, I can only imagine the physical strain, let alone the emotional or mental strain.
Yeah. So it's pretty interesting because I'm at baseline. I'm a pretty positive person. And I honestly don't think I realized how positive I was until this happened. Just thought I was like a normal, just average person. I mean, I am, but you know what I mean? um,
Yes.
but yes, I wanted to get back to work. And like I saw my cardiologist. They did an echo, so an ultrasound of my heart, and my heart function was back to normal. They did an MRI and it was perfect. It's like nothing had happened to it. So they're like, you're good to go. He was like, go back, work out, do what you need to. Like, it's fine by me. So slowly, like, built that back up. The fatigue kind of got better. Then I started noticing a few things. So, like, I started having trouble sleeping at night. I started having really bad memory issues. My husband multiple times would tell me, we've had this conversation, or I already told you. And I legitimately did not remember. This got not worse, but I started to notice more of it, like maybe 2 weeks after going back to work. Things that I knew by heart, I had to relearn. So I think I was in consults and I was in renal, I think. And so, you know, your acute kidney failure or dialysis stuff that I really knew, I didn't remember. And I had to study again a bunch of things and like reread them 5 times. Otherwise it wouldn't stick. Um, it started getting a little bit difficult, like emotionally speaking, when I was when I was back in the ICU where I was. We had a patient that we were seeing. He was on the floor, and he went to have a heart surgery, and he had a cardiac arrest. And then, of course, he was in the CVICU. And the next day, I go to see him, and I was so upset. I was so upset that this had happened to him, and he had a bunch of lines in him. The tube, like I he also, by the way, got chest tubes, so I knew like the pain that he was in, and I started talking to him, and the nurse is like, "Oh no, he's super sedated," and I'm like, "Well, yeah, but you never know."
Right.
So that was like the first one that hit me really hard, and then it started being a few others where if I just heard, the overhead calling a code blue, a cardiac arrest, I would burst into tears, like no reason. Thankfully, I was alone in the team room, but several times it was too much, and it was the same hospital
Right.
where my surgery and everything happened. So start dealing with like all of these things. I keep on remembering, like feeling, well, everything that I was feeling during the arrest, or feeling the pain, hearing what they were saying, and it would just make me cry like multiple times a day. There was like no warning at all, and I was super confused because I'm super positive, and I was happy and I was grateful, but I still felt I felt helpless. I was back to normal. I was working out already. I had my life back. I was with my husband and my mom, and I was happy. But I still felt like super helpless, and nobody around me could really understand. So I tried talking to my husband, to my best friend, and at some point my husband said, "I don't know how to help you. Like, I think you need to talk to someone. That's a professional." And so Baylor actually they give like free like therapy sessions for residents, which is pretty cool. And I started seeing one, and she was like, "Well, yes, this is all very normal for what did she say? Oh yeah, for PTSD." I'm like, "What?" And she says, "Well, yeah, you're PTSD." I'm like, "What do you mean? I don't have PTSD." And she says, "Yes, you do." So that was the first time. This was like 3 months or so into it. And she says, "Yeah, like you have PTSD." Then more things started to happen. Like I had my first anxiety attack when we were in the neuro ICU. One of our patients went into cardiac arrest, and I was there, and I'm like, "Oh my gosh, this is the first one that has a cardiac arrest in front of me, and I don't know what to feel. I don't know what to do." And it was just like a bunch of emotions. And she's like, "Yeah, that's an anxiety attack." So it was a learning curve.
That's yeah, it's something that I think we don't really learn about it as students or even sometimes as residents. You're probably familiar with the book Every Deeply Drawn Breath.
I'm not. No.
No, by Wes, I think it's Wes Ely. He's a critical
Oh
care
yeah, yeah,
doctor.
yeah.
Yeah.
I have not heard that one. Hmm.
But yeah, he was like one of the people who did like a lot of storytelling and I think some of the initial research into like post ICU syndrome and things like that. And it's one of those things where I remember myself as a neurology resident, I would see these people in the clinic. It's like my memory is not quite right or things like that. And older, less healthy people than
Hmm.
yourself.
Hmm.
And you or even people who just had anesthesia for like a complex surgery, things like that, and they didn't come back out of anesthesia quite like themselves. And it's
Hmm.
this really thing that we don't necessarily talk about very much.
Yeah.
And it's we're probably missing a lot of things for people who are going through these situations.
Oh, definitely. I mean, like you said, even as a neurology resident, even though I was an intern back then, but I feel like all of us kind of come in knowing a good amount of things.
Hmm.
Um, I just had no idea that these were things that were expected to be dealing with.
Right.
After, like you said, a surgery or a cardiac arrest or just being in the ICU, period. Um,
Hmm.
and I started paying more attention. And like our patients, the ones that we were consulted on, when they complained about those things, like the memory issues or I have worse headaches, I'm like, "Oh my gosh, I can relate." Like, yes, that's true.
Yeah.
Um, and then I wondered, why are we not seeing these people like as neurologists in clinic?
Hmm.
They go home and like particularly in cardiac arrest or even after ICU, they usually follow up with like their primary care
Right.
or maybe one or two specialists, but very rarely with neurology unless they were seen by them in the hospital.
Right. Yeah, no, it's very true. It's and obviously I'm biased in favor of neurology assessments. Like you said earlier, right? A lot of the information comes from the bedside, talking with the
Yeah.
patient, and having done this for a little while, I'm sure you can sympathize where it's perhaps the next day when they realize after a heart procedure, like, oh, Mr. So and so's left arm's kind of weak,
Yeah.
and you're like, oh, it's because he had a stroke,
Yeah,
and
exactly.
and it's like, but thank you for calling us. But yeah, it becomes one of those things where, and again, right, we are trained specifically for those assessments, and people may not be looking for those kinds of things specifically, and
Hmm.
it can be subtle in some people.
Yeah, definitely. I mean, I did not have any appointments with a neurologist.
Hmm.
So I was just trying to figure out what was going on. And it's funny because when you look up stuff, kind of what to expect after cardiac arrest, none of this is out. I mean, the awareness has definitely increased the past couple of years. And I see a lot more information on it and more resources. But still, I just had to go straight to PubMed. And it took me
Hmm.
a while to find, something that made sense. Um, And I really was like, I want to, like, I would like to have neurologists just follow these people in the hospital and then also in clinic. And as I was kind of looking if any of this was sort of a thing, I found Sachin Agarwal's cardiac clinic in Colombia. And I saw what he's doing, basically following, any cardiac arrest survivor and their families. They see them in clinic. And it's like a one-stop shop sort of. They provide resources. They have, I think, neuropsychiatrists, rehab, a chaplain. Like, it's amazing what they're doing.
Yeah, that's really awesome.
It's amazing. It really is. Um, and it's like the only one in the country, like the only clinic like that.
Yeah. Those types of multidisciplinary clinics unfortunately are challenging to implement.
Yeah,
But
yeah, definitely.
now, have you lobbied this? I know you as a resident you have your own continuity clinic. Have you been accumulating these patients? I know certain people draw certain kinds of others to them for care. So how has that
Right.
affected your actual practice?
So it's affected it in a few ways. Number one, whenever I take care of a patient in the ICU, I think my approach is completely different. Number one, I try to pay more attention to the family than I did in the past. And this also took me a while to understand, but when it was about to be like my first like anniversary of rebirth, whatever, when it happened, my mom was a mess. Like, she was like, I just want this day to be over. And I'm like, but
Hmm.
it's happy, like, I'm here. And she's like, no. And I started to notice that, it's not just me, it's affecting other people too. And then I had already been in touch with a few co-survivors, like wives that their husbands had cardiac arrest, or like Kristen Flannery that gave CPR to Will, and they're like, well, yes, it's pretty bad for us, especially because most of them are the ones that are aware of what's going on and the patient is not so much. So that's one thing. I talk to the family a lot more, like I pay more attention to them. And then I talk to the patients, even if they're super sedated and intubated. I actually explain to them like what I'm doing, as I'm in the room. I tell them, hey, we're going to, or I'm about to check like your reflexes. And I'm sorry I have to pinch you, but I have to see if you can feel me touching you. And maybe the 99% can't hear me, but there's got to be that 1% that might.
You and I, right? I was on call in the hospital last week. I think I saw at least 3 or 4 patients who were kind of straddling the line of brain death, right? And as neurologists, that is just every week that you're going to see that, and you almost build up this protective callus to because it is emotional, right? It's a
Hmm.
lot,
Of course.
and especially for our staff who is primarily in the ICU, it's like if you don't find some way to cope, it's very mentally taxing. But I think that sometimes we kind of veer too far towards that side and become perhaps more brusque and emotionally detached than we probably should be.
Yeah. I initially I thought I wanted to go more towards that side because
Hmm.
the first year it was really, really difficult to deal with these kind of consults, when they call you to neuroprognosticate, or just basically say, hey, yeah, this person is like essentially brain dead. But it actually went more towards the other side. And I started being a little bit more careful, well, a lot more careful actually, with any sort of like prognosis that I gave. And my practice is to wait. Don't just, it's 72 hours when we don't have like a devastating brain injury and the exam is kind of not the best, but also not the worst.
Hmm.
Try not to tell them, well, 72 hours and this is bad prognosis. Because I have seen several cases where it's been like 2, 3 weeks and then the patient, awakes and they're talking and their cognition is intact. And if
Right.
we had actually given a bad prognosis at 72 hours, they probably would not even be here.
Yeah. And there were that the new guidelines just came out like last week. Have you read them yet?
It's a lot. but
Yeah, I
I
I have
am,
not read through them, but it essentially boils down to like don't be too hasty.
yeah.
But I need to dig into them more thoroughly myself as well.
Yeah, no, and they definitely touch more on, like the multimodal prognostication, which I
Right.
think is great and something that we really need to improve and kind of, how can I say this? Like not just be okay with the markers that we have right now because not a lot of them are the best. I think it's only like the evoked potentials, right? That are like
Yes.
pretty good, but not every center does them.
Right.
And
And they're incredibly technically difficult in the ICU. They're
yeah,
so yeah, they're the signal's usually bad. It's technically challenging, et cetera, et cetera.
I mean, I have never seen one. I've never done one, and
Yeah.
all I know is from literature that yeah, it's technically like pretty difficult. So like I think that maybe we need to try to find other markers, if
Hmm.
possible, and kind of go from there. But yeah, I definitely started, and even telling my attendings like, well, maybe you want to wait. It's maybe a little bit too soon. At some point, I actually wanted to emulate what Sachin Agrawal is doing in Colombia
Hmm.
with a clinic, and I went to a couple of my attendings like, "Hey, we have to have this clinic, and it's gonna give everything to the survivors," and they're like, "Sam, like we need resources for that. We need a lot of support."
That that eternal question, yes. Where does the money come from?
Yes, I know. I'm like, maybe we can like convince some people, and they're like, well, back then we only had four intensivists, but they're all
Hmm.
so busy that it's hard
Right.
to have a clinic dedicated for this. And also intensivists usually don't like outpatient,
No.
so yeah. I don't like it, but I was able to to kind of, after like a year and a half of project ideas that were just not feasible, start a QI project, and a few of the residents also got involved, and they were pretty interested in it. And with the help of my program director, we were able to pretty much have the cardiac arrest survivors from our county hospital um, follow up with neurology like automatically
Hmm.
outpatient. And she's helping me so that the referral goes through immediately. There's no blocking it, and then we follow them. Our DS for up to a year, longer if
Hmm.
necessary, of course. But they would have a neurologist seeing them. And then there's like specific questions, of course, also that we would ask that they might not
Hmm.
even like realize, like, oh yes, I'm having memory issues or I can't sleep. So that was like my big win.
That's really excellent actually.
Yeah.
Now, have you got any preliminary data that you can share, or is it still pending analysis?
Yeah. No, unfortunately, nothing yet that we can share. It's taken a while to kind of get it to this point, but I'm pretty interested to see, and one, like how they do to, even if like quality of life improves, if these interventions do make a difference. I'm hoping that it will, but nothing yet.
Absolutely.
So stay tuned.
No, that's yeah, I'll be looking out for it, definitely. One other question I did have. I know that you had said that you're planning on becoming a neurocritical care specialist. Did that happen before? Was that something that developed over the course of your neurology residency, or was that something that you went into neurology residency kind of thinking, I like the ICU, I want to work there with those people?
So I have known that I like the ICU for about 9 years. Um, yeah. So when I was a student, I was in the ICU, and back then I just knew that I wanted neurology. Um, but I was in the hospital. I was in the ICU, and I was the only med student there. There were no residents, no fellows, nothing. And one of our patients comes back from surgery and starts crashing. And then we get, rainbow labs, and they're looking horrible, like shock liver. Um, his oxygenation was really, really bad. I mean, hemoglobin was in like fives, I think, like super, pretty, pretty bad. And he was third spacing, so like all the fluid that we were giving him was just like leaving the vessels and kind of sticking around in other areas that we don't want the fluid to be in. And so, the nurses are like, the attending's not answering, which never happened, by the way. Like, he's
Mm.
super responsive. So I don't know what, well, I think he was sick. I don't know, but he wasn't answering. The other attendings in like other ICUs and the ED, they were super busy because apparently all the patients decided to crash that day.
Oh no.
So they're like, what do we do? And I was like the best thing that they had that day. So I tell them, well, what if we do this or what if we do that? And they're like, might as well. So they started to do it and it worked and he got better. And he, like, we got him stable. I mean, within
Yeah.
like an hour, he was definitely stable. Like, subsequent labs were looking a lot better. And that's the first time that I realized I like the ICU. It was
That
amazing.
must have been a
It
rush.
was. It really was. You know, like doing stuff and seeing it work right there in front of you. It was great. But I was kind of conflicted because in Mexico we don't have neurocritical care, right?
Mm.
So I didn't know how I was going to be able to do neuro and then critical care. I thought that I was going to have to do like a separate internal medicine residency and then
Right.
do critical care and have my neuro knowledge. So when I got my first job here as a research coordinator in a neuro ICU, that's when I knew that, but I found out that there was neurocritical care.
Mm.
And this was like 8 years ago or something. So I knew like this is what I'm going into.
That's awesome.
Yeah.
So have you, I assume, because you're fourth year now?
Sure.
Third year. Did
Mhm.
you already go through the match?
So I'm actually in the middle of interviews.
Oh, well, then we'll keep this on the DL. I
let's
won't
let's
ask you where you want to go most. We'll leave that up
do
to the
not.
future to decide.
Exactly. I'll let you
I'm
know
sure
in
that
August where I want to go.
absolutely. That's awesome. That's so great. So, for people who are neurologists, other healthcare workers of different types, what are the things that you see that, because I'm sure there are more than a few things that you see most often that just really drive you crazy about the way people comport themselves, where they act in the ICU with patients? What are the things that if you could just get rid of them or change them overnight, what's the top of your list?
The top, my number one is stop joking and laughing in a patient's room. It does not matter that they are on, 50 propofol, super sedated, and they're intubated. You just never know who might be aware. And whoever is aware, they're super scared already.
Right.
So to hear that the people caring for them, are laughing and joking is, it doesn't make you feel good. From when I was aware, it's funny because I wasn't scared because I heard everyone just on the ball. They were really doing their best to bring me back. And that gives you a comfort that, I'm not alone. I'm not trying my best not to die just all by myself. There's a bunch of other people that know what they're doing and they're helping me. So that's the number one. And then number two, don't neuroprognosticate so early on.
Yeah. Do you ever find anyone trying to go before 72 hours?
Yes.
Oh, that's a
Yeah.
no-no, isn't it?
Oh, yes, it really is. Yeah, you just have to remind them, it's one, not appropriate, and two, it's you could be killing someone if you give a prognosis, well, a bad prognosis before that time.
Yeah, I first came across this phrase when I was in the neurocritical care issue of Continuum from last year, and I really should look up the author to give her credit. But she
Carolina,
was. What do you know her?
Carolina Maciel. She's actually one of my mentors.
Oh,
She's my
oh,
yep. I love
but
her
yeah,
work.
she used the phrase medical nihilism for this self-fulfilling prophecy in
Hmm.
neuroprognostication, and it really is, and it's such an easy trap to fall into,
Yes.
especially with all of these people coming in, like opioid overdoses. They were down for an hour, all everything stacked against them. And so it's very much like, well, that all makes sense. This looks like a very bad picture and it will probably end badly. And then, well, we prognosticate as such and family, terminally extubates the person. And, well, look, they did badly, just like I expected they would, right?
Yeah.
And everything lines up. All of our expectations are met. So it is such a logical trap to fall into, logical in air quotes. But
Right, right.
but yeah, how do you? I mean, obviously with your own personal experience, but how do you keep people from falling into that trap?
So it's been challenging. Particularly when you're talking to people that have done this for like longer than a decade or two.
Yeah.
And I do understand that my case is not everyone's case, and there's data out there for a reason. But I think you need to think of that 1%, that 2%, of people that maybe don't fall into the norm. And imagine if that person was you or your family members. What if it was your mom? If it was your spouse? You would not want, your own bias to cost their lives. So I just I tell them this honestly. Let's give the care that we would want for ourselves or for our families, because these people are not just a patient. They're somebody's daughter. They're somebody's mom. Somebody's husband. And so treat others how you would want to be treated.
Yeah, I think that's the best we can do. How do you deal with, because as you said earlier, right, a lot of our tests for neuroprognostication, MRI has low sensitivity. If they have intact cranial nerves, right, particularly the pupillary reflex, the corneal
Mm-hmm.
reflex, I mean, those are the two that tend to correlate most, as I'm sure a lot of our listeners are aware. They're not brain dead. They're not waking up. Testing is normal. Now what? How do you mentally wrap your head around that?
So there was um there was a speaker at AHA last year,
Mm-hmm.
and she she showed some data of some cases in Europe, I believe, that people woke up. Well, physicians waited, I think, up to 30 days, in some cases, and eventually these people woke up. So, because of the way that our rotations work, I can't unfortunately like follow them the entire time. But I think the key is just hope. I hope that whatever brain injury or other pathologies going on will slowly subside and chill, and they will be able to wake up. And if they don't, they truly will just not wake up.
Mm-hmm.
Um, just hope that the family like has the ability to accept it and find that those support that they need and the resources that they need in order to move from it. It's still pretty difficult, but
It is.
it's hope.
Yeah, I find those patients, I would mostly put them in kind of like the minimally conscious state category. Those are, I think, the most challenging ones because they're reacting to their environments, but they're not themselves, and it's like some of them, like you said, they will wake up and they probably will improve, but there's still a large percent that may not and may remain in that state, and that's the really challenging part is
Yeah.
you don't know who is who.
And when you take into account external factors like insurance, or do they have the means, the financial means to keep this
Right.
person, in an LTAC, or I don't think nursing home would be the appropriate place, but let's
Right.
say an LTAC, um, or even take them home, like when they don't have that, and they want to give their family member a chance, like what do you do? And like here in our county hospital, we recently had a case of something similar, post cardiac arrest patient. Brain injury wasn't devastating, not from what we could see in imaging at least. EEG was not bad, just low. Exam wasn't crazy horrible, but still just not waking up. And the family had to make a decision because they were not citizens of this county, of Harris County. So they couldn't get any sort of medical benefits and they didn't have the means. So they had to base their decision solely on, well, can we afford this?
That's terrible.
Yeah, yeah. It's complicated. I don't think that we'll find, like the right answer anytime soon.
Yeah. No, no, it's definitely a lot of pieces and very complicated.
Yeah.
Now, you've also been involved in some advocacy work, is that correct?
Yeah.
Tell me a little bit about that.
Yes, of course. So one of the things that I did when I started realizing that I needed some support from others that had gone through the same, I looked up some support, group survivor networks here in Texas, and I couldn't find any. There's a few for like youth cardiac arrest, but clearly I am not in my teens or early 20s. So I needed to find like a grown up. So I needed to find something that was more for me. Um, and I couldn't find anything. I talked to Dr. Bentley Bobrow, who is, I think, the head of CARES here in Texas. And I was like, hey, is there anything here? He said, nope, there's nothing. Like, but you could start something. I'm like, I think I could. Um, so I created the Texas Cardiac Arrest Survivor Network, which is essentially the only, survivors group here in Texas. It's in its very baby stages. It takes a while to kind of grow it, but we've been able to, reach out to some people, help a few others. They're telling their stories. My thing is like providing evidence-based information, but in very simple terms, because I don't, it's impossible, I think, to reach like your entire audience. But if I'm
Right.
able to help those with low health literacy as well, which I think are the ones that mostly need it, then I've done something good. And so I try to keep it just very simple, to the point. There's like little meetings. They have been all over Zoom, because COVID. But just even them, like finding someone that they really connect with, another survivor that they can talk to, and that hopefully they don't, they don't have to go through what I did, and like trying to figure out who to talk to, who to connect with. So that's a one thing. And then Dr. Benabella from Penn was the first one to actually reach out to me on Twitter, and he invited me to talk at his cardiac arrest course that he leads biannually. And so I started talking about my story, and I reached a few people. Then I actually reached out to Sachin Agarwal from Colombia after reading his paper on PTSD, and he took me under his wing. Carolina too. They're like, yes, like I can help you. And through them, I was able to connect with more survivors, more co-survivors who have dedicated truly their lives to, raising awareness, and even like the effects of brain injury. There's a friend that had pretty severe brain injury from her cardiac arrest. And you look at her and you would never think that today. So thanks to all of them, we have been able to, come up with certain initiatives to really help people in what happens after they leave the hospital. So that's been pretty cool.
That's some amazing like network building, and yeah, it's very impressive.
It's all thanks to Twitter, and I think my cardiac arrest um, had to bring something good.
Well, that's that optimism coming through again, right?
I guess, yeah.
Yes. Any final thoughts that you would leave our listeners with about cardiac arrests, about the heart and the brain in general? Anything that big take home points?
No, for sure. So I think the big thing would be, and mostly for our fellow neurologists, be careful. Be careful with those neuroprognostication consults. Don't just give a bad prognosis right away, especially if the exam is looking a little bit iffy and you don't have anything for sure. I know it's hard. It's hard to say, well, yes, this person could wake up. But again, just imagine if it was you, or if it was your family member. Just give them the chance that you would like to have. And I guess for the entire audience, the brain and the heart are definitely connected. They are pretty connected. And advocate for yourself, for your patients, for your family. If this ever happened to, to you or to your loved ones, just advocate to get that support to, maybe see neurology if you think that there's something going on, if you're having memory issues. Just fight for you, fight for your care.
That's something I always tell my patients. It's bring someone. It's always good to have someone who can fight on your behalf.
Yeah.
Because sometimes it's hard to do it yourself.
Exactly. Especially when you're if you're sick, right?
Right. Absolutely.
So yeah. No, definitely do that.
Dr. Samantha Fernandez at Baylor, a amazing story. Thank you so much for sharing all of your experiences and all the work you've been doing. I very much look forward to seeing. I'm sure you'll be a pillar in the neurocritical care community for decades to come.
You're so sweet. Thank you so much for having me, Michael. It was really great talking to you, and thank you for inviting me. I hope that this can help, a people or two out there.
Thank you so much. Thank you, everyone, for listening. If you enjoyed this podcast, please rate, review, and share it on Apple, Spotify, or wherever you get your podcasts, and please subscribe for future episodes. You can reach me on Twitter at Dr. Kentris, that's DrKentris, or by email at theneurotransmitterspodcast@gmail.com with any questions or show suggestions. We'll see you all next time.